Hello, everybody. Welcome to today's Consortium of Universities for Global Health webinar on transforming the World Health Organization by strengthening its science, data, funding, and governance. The pandemic has shown in stark relief the public health threats know no borders, and has also shown that only multilateral efforts will enable us to address those threats. Also, it's shown in stark relief how global inequities are with us, and also how the pandemic has made those inequities vastly worse, including, in particular, access to vaccines, which are critically important to addressing this global health threat. Now, central to the efforts, of course, to address these public health threats is the World Health Organization, the only global multilateral organization that has the mandate to address these and other global health threats, to improve the health of all people, but particularly those who are most vulnerable in our world. But the WHO, of course, is us. It's 194 member institutions that determine the WHO's policies, supervise its financial policies, reviews its budget, and elects the Director General. And of course, there's the 34-member executive board that actually puts forward to the World Health Assembly what those policies and recommendations should be for their consideration. Now, how can we strengthen the WHO? How can we ensure that it has the funding and the actual ability to carry out the vital mission that it is engaged in to support its many workers around the world who are working tirelessly to improve all of our health? Well, today I'm glad to say we have an absolutely stellar panel of leaders within the organization, and in the order in which they'll speak are as follows. Dr. Peter Singer is a special advisor to Dr. Tedros, the Director General. He was the founding CEO of Grand Challenges Canada. Dr. Singer will speak about funding, and he'll talk about strengthening governance in the organization. Following Dr. Singer will be Dr. Soumya Swaminathan. Dr. Swaminathan is the chief scientist at the WHO. From 2007 to 2019, she was the Assistant Director General for programs at the WHO, is a pediatrician, TB, and HIV researcher of international renown. And following Dr. Swaminathan is Dr. Samira Asma. Dr. Asma is the Assistant Director General for Data, Analytics, and Delivery for Impact. She was a leader in the DCP3, particularly for non-communicable diseases. Now, after they speak, we're going to have Q&A, so get ready to submit your questions. We'll have a wrap-up, and then we'll close. So I'm going to turn it over to Dr. Singer. Dr. Singer, thank you for being with us today. The floor is yours.
Thank you. Thank you so much, Keith. It's wonderful for Soumya and Samir and I to be here with you. We're very, very happy to be here with you and with all the people watching and listening. I want to start, Keith, by thanking the CUGH, yourself, and actually all the participants for everything they've done, everything you've done in the pandemic to address this critical threat. And it really illustrated how we all have to work together. And I don't think I could put it any better than you did when you said WHO is us. What I'm going to do is just frame this conversation a little bit and touch upon governance and funding, as you mentioned. As I think is clear, WHO is completely focused on ending the pandemic, preventing future pandemics, and then recovering to the Sustainable Development Goals, because we're way off track now in terms of the SDGs. I think it's important to say, though, there's a big trough between ending the pandemic and everything else, and that is the fair distribution, the equitable distribution of vaccines. And it's a little bit hard to put the gaze longer term when we're focused so much on ending the pandemic with the public health measures and with the vaccines. We've all learned lessons from this pandemic. And, for me, one of the key lessons has really been lessons around equity, lessons around justice. You referenced this, Keith, And in some ways, the pandemic has been an X-ray of our character, has been an X-ray of our soul. It has been a triumph of science. And I think we're still working to pass the second test, which is that of humanity. Science and innovation are, along with data, extremely important in these issues that Soumya and Samira will speak about. Vaccine justice. Now there's a lot of vaccine injustice and inequity, maybe one of the biggest challenges we face. And of course, the broader equity issues that require disaggregated data. And in some sense, at the moment, perhaps we should think about this as a Mandela moment. Everything seems impossible until it's done. And ending this pandemic is the thing that needs to get done, and that can only get done together. One of the points I want to emphasize is that WHO, under Dr. Tedros' leadership, since 2017, has been undergoing a transformation which has focused the organization on impact at the country level. And this means that WHO was transforming before the pandemic, during the pandemic, and it will be transforming after the pandemic. WHO is always learning lessons, and we continue to do so. Probably one good proof point for this notion of impact at the country level is the $3 billion target that was set in the essentially our strategic plan, the general program of work, approved by member states in 2018 under Dr. Tedros' leadership. And this was setting a target across the organization of 1 billion more people having access to universal health coverage, 1 billion more people better protected from health emergencies, and 1 billion more people living healthier lives and with better well-being. And these are very heavily SDG-based targets. And not only were those targets set, but they were also measured. And as Samira will show, and as Dr. Tedros discussed in his speech at the World Health Assembly this past spring, some of those targets are going better than others. And the one that is really falling behind is the target on universal health coverage, where we estimate that even before the pandemic, only 290 million people will increase in terms of benefit of universal health coverage out of the billion between 2018 and 2023. And that really requires us to double down on primary health care. On the emergency target, the numbers look okay. And these numbers are all also in our 2021 results report, which I would encourage people to read, covering the year 2020. 920 million out of the billion. But what I think we've learned from the pandemic is that we have to raise our ambition on preparedness, and also that our measures need improvement. You know, it's not enough to measure the static capacities. We need to measure the dynamic decision-making, and things like some of the softer things like trust in government become very important and determinative, actually, of cumulative mortality. And then finally, on healthier populations, we project that during that 5-year period, 900 million people will benefit from increase in health and well-being. But it's very inequitably distributed across countries and across themes. And as I say, Samira will discuss this more and what WHO working with you can do about it. But I just wanted to use this $3 billion target, quantitative targets across the organization that are measured and then that are addressed to support countries to close the gaps as a bit of a proof point of this focus on impact at the country level, even before the pandemic, during, and after. Now, we've already discussed, I just mentioned, the extreme importance of primary health care before, during, and after the pandemic, and also future preparedness issues. Today, we're going to focus on science and data and partnerships. And one can think about these as superchargers or accelerators of progress. If we're way behind on the SDGs, for example, these are ways to accelerate progress, close the gaps, because business as usual won't do the trick. Just to touch upon the two issues, Keith, that you raised, governance and finances. In terms of governance, of course, one of the comparative advantages, one of the strengths of the World Health Organization is that it is governed by 194 countries, 194 member states, and we have 152 country offices, a very important footprint. And I think one of the issues during the pandemic and after the pandemic is really that support to national governments and the inclusion of every government in, for example, preparedness, because we're only as strong as our weakest link, and a pandemic can start anywhere and it can end anywhere. And so that inclusive governance, inclusive country engagement, actually in 194 countries, is, I think, a very important piece of governance. The governance per se of the organization, of course, is up to the member states, and there's a couple of committees working now towards a special World Health Assembly later this fall on these preparedness issues. The other bit of governance that's really important is the governance in the global health ecosystem as a whole. WHO leads something called the SDG 3 Global Action Plan, which is working to ensure that multilateral agencies, 13 multilateral agencies or partners, are working very, very closely together towards an equitable and resilient recovery towards the SDGs. And naturally, partnerships with civil society, with academia, with the private sector are also very much our focus. And actually the focus of this webinar, because we would like to work with all of you and the incredible networks of CUGH in terms of ending the pandemic, preparing for the next one and mitigating that and recovering to the SDGs. In terms of finance, the annual budget of WHO is just less than $3 billion a year, which is the budget that's smaller probably than many of the hospitals and academic health science centers that the people listening to this work on. And there's really two issues here. One is the size of the budget. And then second is the flexibility of the funds. At the moment, less than 20% of that budget is in flexible funds or assessed contributions. And so that doesn't really provide the flexibility that the leadership of the organization needs to address nimbly needs that come up. The international panel, the external review of the international response to the pandemic recommended that that figure be increased to 2/3, and there's more than 2/3, and there's a very active discussion going on that. So what I wanted to do, Keith, in these remarks is really frame the discussion as a WHO that's very much focused on impact at the country level, that was transforming before the pandemic, that has learned important lessons, as have we all during the pandemic, and that will be vital to ending the pandemic, preventing a next one of this scope and scale, and supporting countries to recover towards the Sustainable Development Goals on a waft of other very, very important health indicators and health domains that many colleagues on this call would be working on. And what I want to do now, Keith, is just hand over to a couple of fantastic colleagues, fantastic leaders in science and in data who are really helping the organization with these accelerating areas. And there's been an incredible amount of progress in both of these areas. And in our strategy, these are very much cross-cutting areas, very much influencing everything that WHO does, and very much helping the organization to work with partners to help countries to accelerate back towards the world that we all want, and the healthier and fairer world. So with that, Keith, I want to thank you again for this invitation, and very much look forward to the comments from my two fantastic colleagues who are about to speak. Back to you, and thank you so much.
Thank you very much. Thank you very much, Dr. Singer. That was a fantastic presentation. And I'd like to, as you mentioned, turn it over to Dr. Swaminathan. Dr. Swaminathan, please, over to you.
Thank you very much, Dr. Martin. I'm going to share my screen now because I have a few slides I'd like to project, and I just want to confirm that you can see my screen.
We can see it.
Yes.
Thank you. So, so Dr. Singer gave a very nice introduction about the way that WHO is changing, and what I want to do is to give you a bit of a peep into what the science division is doing. I'm really very honored and humbled to be the first chief scientist of WHO. The science division was created in 2019, just about 9 months before the pandemic hit the world, and it really tested us and showed how important it was, and it also really underlined Dr. Tedros's vision and foresight in having considered the need and for a science division in WHO, because science was always implicitly part of WHO's work, of course, but not as explicit as it is now. So I just want to take you through some of our goals and how we see we can make a difference. And I'll be touching on some topics, not all, because we only have 10 minutes. So one of the things, of course, we want to focus on is on research. And again, we've seen during this pandemic how important it's been, how science has worked to deliver the solutions, and why you need research, R&D, but also other kinds of research capacity across the world. So here you want to go right from the upstream, where you want to be able to anticipate the scientific and technological shifts that are coming, so what is called horizon scanning. And every new technology comes with a lot of benefits, potential benefits, but also some potential risks and downsides which have to be managed. So as an example, we recently came up with 2 publications. There were 2 very high-level expert groups set up, one to look at the governance and oversight of human genome editing, and the other one on the ethics and governance of artificial intelligence in health. And as you can imagine, both these technologies, genome editing and artificial intelligence, have huge potential to be used for healthcare, but also some ethical, legal, regulatory challenges which can be addressed. But WHO is in a good position to tell the world what to expect and how to address those. The other one is looking at research agendas. So when we think about research priorities, what happens today, the reality is that much of this is driven by funders and donors in high-income countries. And researchers in the low and middle income countries are often driven by the grants that they can get, not necessarily by their local priorities that they need to be working on. And so helping them set their own local health priorities, but also, of course, having a global health research agenda and having proper methodology to do that. And one of the recent examples is a blueprint for dementia research, because compared to communicable diseases, non-communicable diseases in low-income countries has received less focus, even though it takes actually a bigger toll in terms of, premature mortality. And so we thought it's important to start with something like dementia, where obviously you need a lot of research, not just in developing new drugs, but in implementation research, in strategies that can be used to care for people in low-income settings. And then the Science Council, which was again established by Dr. Tedros recently, is a good example of a link between WHO, which usually works with ministries of health, and the wider global scientific community. And we have a Science Council. The inaugural council has 9 members, of which 2 are Nobel laureates. And they've just decided that their first topic on which they're going to focus is going to be genomics. The second big goal is around updating our guidance, what we call our norms and standards in real time, and putting in place processes for updating public health and ethical and clinical guidance, what we call the living approach to guidance, which is that you don't wait for 5 years to then update your guideline, but you look for changing. And again, COVID allowed us to do that because of the rapidly changing evidence base for the use of drugs. For example, we now have a living approach to the therapeutics guidelines for COVID. And of course, our whole, one of our, almost a bread and butter of WHO is to produce the normative guidelines and standards and data products. And so these need to be very much rooted in what people need, what countries need, and to be delivered in a way that's user-friendly, timely, and still of the highest quality. So even if you're dealing with an emergency, you have to balance speed and make sure that it's still based on real evidence and data. And then making it widely available using digital formats much more than we did in the past. And then another area is around digital health, but also innovation. Innovations beyond digital health. So again, an approach of doing guidelines, what we call smart guidelines, where you can actually get them on your mobile phone in a way in which you can rapidly search through guideline to find exactly what you want. And if there's a healthcare worker in a remote area, he or she should be able to download a clinical practice algorithm, for example. Then our emphasis, where we work again with Samira and her colleagues on data coming from research, coming from patient care. How do we get global collaboration and sharing with around research so that we can apply things like artificial intelligence and machine learning to get more out of the data that we collect? And then the innovation hub that will be collecting, that will link the needs in countries with the globally available innovations. We have a global strategy on digital health that's just been approved by the World Health Assembly. We have a 5-year implementation plan. It's essentially now, we all know everything is digital now. So the future health systems are also going to be built on digital platforms. Some countries are further ahead, others are behind, but everybody now needs to leapfrog into the new era, which means that you need governance standards, you need interoperability, you need to look at how you're going to manage those digital platforms in countries. You're going to have to look at cybersecurity, and you're also going to have to improve digital health literacy in a big way and set some standards and guidance on how these tools are going to be used. Behavioral insights. Now, again, Dr. Tedros was visionary in that he set up a behavioral insights group even before the pandemic hit, because we know that to have an effective public health response, you need behavioral insights because of all of these issues around trust, around misperceptions and stigma. So Dr. Tedros said at the beginning of the pandemic that we're not just battling the virus, but we're also battling trolls and conspiracy theories that undermine the response. And so our response to that was to innovate in unprecedented ways in order to still continue to give that credible message to people who need it. So because we are living all in a digital age, because we're living in a social media age, we started working with the tech companies. All of the big tech companies agreed to collaborate with us, and you see them listed here. And we focused on 3 areas of work. One is to promote life-saving health information. So when people search for something, they should first get credible information, either from WHO or from some other public health agency. Second is to fight misinformation and falsehoods. We flag to these companies anytime that we see misinformation circulating. We're constantly monitoring, and all the tech companies take it down immediately. They have agreed to do that. And third is, when you monitor social media, you get a feeling for what people are talking about, what their concerns are, whether there are some misconceptions that are circulating, and then we address them through things like our Science in 5 series, where in 5 minutes, under 5 minutes, we address the hot topics. And many of them today are around vaccines. And this, obviously you can reach billions of people when you use these platforms. Innovation, just a quick example on solar-powered oxygen concentrators in a hospital, in district hospital in Somalia, which never had oxygen before. Thanks to the Innovation Hub, we were able to link the solar-powered innovation to a hospital that needed oxygen, and now we're able to treat both adults and children with oxygen, which of course is a life-saving essential drug that goes way beyond COVID and can probably save many more lives in normal years when people die unnecessarily of pneumonia. I spoke about the living approach to guidelines. Our previous approach was, you wait for things to become outdated, take several years, and you start again, and then you go through a cycle of updating. And and very often you are behind the curve. The living approach is when you're using foresight, you're regularly updating, you're adapting it at the country level, and you're using digital delivery. And then on health research, I mentioned that we set up the Science Council, we have a health foresight function. We also have something like the Global Accelerator for Pediatric Formulations, which is a partnership of about 30 agencies who are all dedicated to developing and delivering pediatric formulations for common diseases like TB and HIV. I mentioned ethics. Our ethics working group has been very active during the pandemic and has produced recommendations. I mentioned genome editing and artificial intelligence, but there's also ethics on ethical frameworks developed for many other products. And I should probably stop here and hand it so that we have enough time for discussion at the end. But evidence to policy is another area that we can talk about later, how it's not just enough to have the guideline, you need to have it implemented. And that's where our regional and country offices play an important role in taking the global guidance and then adapting it to the local context and working with the member states, working with the ministries of health or other ministries as the case may be, to actually implement it at the country level. And then, of course, we have research capacity strengthening. We have the research entities. We have the Tropical Disease Research, TDR. We have the Alliance for Health Policy and Systems Research and the Human Reproductive Research Program, all of which have come under the science division for the first time. So we have a core group of research entities that are working with particularly researchers in low and middle income countries. So I think that's a lot that we've actually learned from this pandemic about how science can find the solutions, but you still need to pay attention to equity, to ethics, and to human rights. And we need to be able to use the advances in digital technologies in order to reach people, to provide the right information and access to tools, but also address the misinformation, which unfortunately today seems to be a very big problem globally. Thanks very much. And back to you, Keith.
Thank you very much, Dr. Swaminathan. Thank you very much, Dr. Swaminathan. That was a superb presentation. We look forward to a lot to review, and I'm sure we're going to get lots of questions about that, the important work you're leading, WHO. Dr. Asma, are you on? And we can turn it back to you.
Yes, Dr. Asma is here.
Wonderful. Dr. Asma, please, over to you. Thank you.
Thank you. Thank you, Keith, and distinguished participants. We are extremely delighted to be able to talk to you today and have this dialogue. I want to begin by saying that one of the greatest lessons that the pandemic is teaching us every day is the value of timely, reliable, and actionable and disaggregated data if we are serious about addressing inequalities and closing that gap. And as the pandemic has also shown, and often in public health, we are dealing with a virus or an agent that is faster than us. And tragically, this is costing lives and livelihoods. And our response should be quicker and better coordinated. So the point I want to make today is that we have the means and the tools to be ahead of the curve. And data plays a very central role in how we manage to do that. And the pandemic has created an unprecedented opportunity for us so that every country must have and could have and should have timely, reliable, and actionable data. And we at WHO, as Peter highlighted and Soumya mentioned, are driven by evidence, the science, the data, being accountable to the member states and to the people we serve. As Dr. Tedros says often, we cannot make progress if we cannot measure progress. So how far we have come along since the transformation at WHO? We have begun already laying the foundation. And we have a strategy, and that is being underpinned by a results framework and accountability framework that is harnessed in the 3 billion targets, that is a means to count everyone so that we move systematically towards the 2030 agenda, 9 years away. We needed a mechanism to have a health information system. So we launched the Score for Health data technical package. And now we are at a phase of strengthening and accelerating. Strengthening the data systems and data gaps, liberating data through the World Health Data Hub, and making sure that we are driven by data to ensure that we are tracking where we are at baseline, where we will be in meeting our targets, and what are the trajectories that can be influenced by the right priorities and policies. So those are the 3 priorities we have in the division of data analytics and delivery for impact. Like the science division, it is a cross-cutting and an enabling function for each of the 3 pillars. So we have populations that are living not only longer lives, but healthier lives. We have a world that has access to universal health coverage without financial hardship. And when the emergency strikes, when there is an outbreak in a community, before the outbreak turns into an emergency and an emergency into an epidemic and a pandemic, we are able to address that in a fast way, all again driven by strong data systems. So what we found this year when we did the first ever global assessment of countries' data and health information systems through the Score for Health data technical package, what we found, I'll just give you an example, and here you see the score, which stands for surveys, CRVS, civil registration and vital statistics, optimizing routine health information systems, and reviewing the progress and performance and the investments in this from countries. And finally, what is good of use of data if we don't use it to deliver or enable the for policy and improvement of programs and performance. So striking results. Only 27% of countries are able to have sustained capacity to survey health threats. And it has been very evident from the pandemic. Even countries that had informed that are prepared, and where perhaps if you imagine a world map would be green, we have seen those countries were not adequately prepared. And as a result, the world was caught inadequately prepared. Let us look at civil registration and vital statistics. Why is it so important? And why was it so neglected? Only 4 out of 10 deaths are registered. We are guesstimating what the COVID death toll or the human toll of COVID is, of the pandemic. We are relying on guesstimates because of weak civil registration and vital statistics. When we look at zoom into African subcontinent, 9 out of 10 deaths go unregistered. We are talking about not getting registered. Let's look at causes of death. Weak capacity, that has been a very big challenge as we are responding to the pandemic and COVID. This has to get corrected, and we have some solutions in the works now, scaling up rapid mortality surveillance in countries. Optimizing routine health information systems become extremely important when we want to ensure that every country has integrated disease surveillance systems, health facilities, and the supply chains all integrated, so that every country is again prepared. And we see again variable capacities across the continuum of SCORE. We also launched the tools that back up these 5 areas of capacities that are necessary. So now we have the tools, we know where the gaps are. Now is the time to rapidly address and close those data gaps. We don't need to wait for the next 9 years. We can do it now, and we should collectively do it. Not single agency, single country can do it alone. And the CUGH is a great platform that we can really attract partnerships and insights and minds to come together so that we can accelerate not only data gathering, collection, curation, but analytics and how we use data to improve performance and hold the governments accountable. Moving to next, the member states requested WHO to have all health data in one place. Lot of data fragmentation, and we have had not a very good opportunities now. Many individuals and agencies have come up with many dashboards and many good data systems. What we need is the connection so that we have all health data in a single repository that can be accessible. We have a direct secure channel with the countries for countries to deposit data to WHO and for WHO to assess and have the consultations when we produce the estimates. An easy to download data warehousing system and truly a world-class experience that allows predictive analytics, machine learning, and etc. So this is in the works. We will have sprints that we will be launching. The first one will be looking at COVID deaths, launching in September. And we are very fortunate to have many public-private partnerships in building this world-class World Health Data Hub. We are grateful to the partnerships from ESRI and Microsoft and many other technology institutes and agencies that have come forth providing the support. Finally, and Peter highlighted this with regard to the $3 billion and how far we are, it is a means to see if we will be able to achieve the 2030 agenda. And we have already seen, this is before COVID. We are working to take the impact of COVID into account and see how far we are. So we not only have to get back on track because we have faltered, it is most important that we accelerate the progress. And we can only do this drawing on from the data and setting those targets and trajectories and prioritizing what will it take. We need good guidelines, as Soumya mentioned. We need good surveillance systems for various indicators, whether it's malaria or TB, tobacco, HIV, hypertension. We need good data systems. Similarly, universal health coverage and financial hardship. The data to gather financial hardship is important. And how do we do that? We need good data collection mechanisms. So we have launched the World Health Survey Plus, a platform for multi-topic, multi-mode data collection systems. And similarly, for health emergencies protection, we ought to be making sure every country is preventing, better prepared, and also have the capabilities for timely detection and response. So this is the work in progress. Look out to the link there and see how each country is performing across various indicators that support each of these $3 billion indices that are SDG related. And finally, the point I would like to make is about partnerships. And the work, first, we have to make sure that we are assessing the direct and indirect impact of the COVID pandemic. We are working with partners. 40 experts, modelers from all around the world are a part of the WHO UN Division of Statistics Technical Advisory Group doing this estimation that will be released for 2020 and halfway into 2021 soon in September this year. We already released 2020 estimates where the official statistics or data that was submitted to WHO that was reported was about 1.8 million deaths, official reports in 2020. The excess deaths were 3 million, that is 1.2 million were the excess deaths. And pandemic is still unfolding. Every day we are getting the reports of people dying. So all of that will be taken into account across this very rich analytic expertise from all over the world, helping to define the methodology and to begin data collection already in the works, fast tracking that data collection on deaths and causes of deaths, and have the estimates. Health Data Collaborative is a platform of over 60 partner organizations from multilateral to civic society and academic institutions. Join us. We are working to have an aligned approach and share the resources so that we can support the countries in a more systematic way rather than rushing and asking for data at optimum number of times, but being smart and efficient about it. And finally, I would like to close with the SDG Global Action Plan, the Data and Digital Accelerator, because technology can help accelerate, address the gaps that we have, ensure that the primary health care really comes to life so that we can realize the universal health coverage, health for all ambition and vision. So with that, I would pass it back to you, Keith, and thank you so much. Look forward to the dialogue.
Wonderful. Thank you very much, Samira. And that on the bottom was Dr. Samira Asma, who was kind enough to, she was using Dr. Swaminathan's office. So that's efficiency happening at the WHO.
Right, we had to shuttle between offices, which are about a few kilometers from where we were. So thank you, Soumya, for offering me your office.
Well, that was you both did that very, very quickly and cleverly. So, so please, thank you so much, Peter, Soumya, and Samira. We're going to go to Samira. We're going to go to questions now from the audience. But I'd like to first ask, while you're loading in your questions, please do so now. I'd like to ask Dr. Swaminathan, I mean, it ties into Dr. Asma's questions about partnerships. And we work with low-income countries, as you have, to try to strengthen their capacity. Both of you are talking about capacity building. Can you share with us, and you worked hard on building South-South collaborations to strengthen capacity, to make sure that low-income countries' priorities are met, not what grantees' priorities want. Very important point. Can you share with us what the WHO is doing to strengthen Ministries of Health's capacity to be able to deliver the public health goods that they're trying to do? And maybe just share how universities can play a role in that, please.
That's an excellent question. I'm sure the others would like to chip in as well. I think universities can play a very important role, but not by themselves. So the first thing, we are working with Ministries of Health to promote research as part of their health systems response. We call it learning health systems. You know, health systems need to keep innovating, they need to keep learning, they need monitoring and evaluation, and they need operational research. Every time you introduce an innovation, it's good to be able to see whether it's having the impact you wanted. And this is something that academics can do. But if you leave academics alone, then they go off and study. This has happened to me in my own career. You know, I'd go off, do a piece of work, and then go to the ministry and say, here, we found your solution. And they said, well, this wasn't the question that we were interested in anyway. So you can go away and publish your work, but it's not going to have an impact on what we do. And then I learned that you have to go to them before you do your research and ask them, what are your challenges? What are your problems? And how can we help as a group, as a consortium, solve it? So when you have partnerships with the public health officials, that's when you can actually start making differences and when the research can start having an impact. So that's one. And the second, of course, is for people to start focusing on their local health problems. And I think a good example is the R&D blueprint for epidemics was set up in 2016 after West African Ebola, because the research there was so fragmented. That's come in very useful now, but even before the pandemic, Dr. Chikwe at the Nigeria CDC actually leads a consortium of academics in multiple West African countries, all of whom have Lassa fever, and have agreed to work together to learn more on the epidemiology of the disease. And then when diagnostics and vaccines become available, they will actually have the sites ready with the local epidemiology to be able to undertake those clinical trials. I'll stop there.
No, thank you, Dr. Swaminathan. And here at CGH, we're working with Sierra Leone on strengthening. You mentioned dementia. We're working with them to strengthen their mental health capacity, but there are only 2 psychiatrists in the entire country, 3 mental health care nurses, and no clinical psychologists. So, and the Ministry of Health has only 2 people. So your work in that country and others are vitally important to strengthening ministries of health. So thank you for that. Dr. Asma, to lead on to, as a lead off from Dr. Swaminathan's question about, you mentioned the SCORE country data health capacity, and how you're working to strengthen the ability of countries to make sure that their own data is going to be produced by their own people. Would it be helpful to have an independent data board with representatives from country statistics offices on that can actually be able to evaluate the data that comes and share that publicly? Would that be useful in strengthening the WHO's work in data work?
Absolutely. I think we really need all stars aligned. For an optimum health systems to function, we need at least 14 or 15 data streams. And this is not only the responsibility of the Ministry of Health. We need Ministry of Justice for CRVS, Ministry of Interior, national statistical organizations that are very good at collecting, doing surveys. It need not be Ministry of Health doing that. We have academic institutions that have superb analytical capacity and interfacing. So that is the alliance that we are looking at in each country. But when we go a little above, we really need to connect the strategic advantages that many of the academic institutions have offered and are offering, and build those bridges. So that's what we are doing, collaborating with many universities in all the continents and trying to create a program called Championship in Data and Health Information Systems, mentoring, linking with the National Institutes of Public Health. Unless we create that whole alliance in each of the country, as Soumya mentioned, it will be a research or a thesis that perhaps could have had more impact if it is linked with the policy of the country and the priorities. And we are also connecting and will welcome universities to come and join and share work together, and open to that, and look forward to working with you, Keith, on taking this idea forward.
Thank you, Samira. An independent data board would to help to work with you on that would be really outstanding, because you're doing so much work in that space, the WHO. This question goes to governance issues. I know the independent panel has spoken about this. Previous reforms have discussed how to strengthen governance in the WHO. Reforms are being proposed. There's a couple of proposals on the table. They might be discussed at the special meeting in November. Would a permanent executive board be helpful? That would help to insulate the WHO from the efforts of member states to influence its activities. And part of that goes hand in hand with having robust hiring procedures and evaluation procedures and monitoring evaluation, including at the country offices, to be able to actually make sure that the WHO, as I mentioned, is insulated from the efforts of its member states to be able to influence the hiring practices and procedures at the WHO.
So Keith, let me just say 2 things. And this is from the standpoint of someone who has been in the shoes of academia as a professor of medicine, been an innovation funder. And 2 points. One is just to round up the points that Soumya and Samira were making. The headline here, and I think everyone realized this, is WHO operates at scale. It is an incredible platform at scale with 194 member states, 152 country offices. So to each person who's listening to this webinar, either now or in the future, I would just reiterate what both Soumya and Samira said, which is work with us. And what you said, Keith, which is WHO is us. Tweet at us. I'm at Peter A. Singer. Samira and Soumya will share. We want to work with people on this call, your membership, Keith, And there's some fantastic people that are listening to this. I can tell from the tweets that are already going out. And we need each other for the generation of ideas and then to amplify those ideas at scale. Now that leads into your specific question about governance. Governance is obviously a matter for the boards themselves. That's just a fundamental principle of governance. And in this case, the board, if you will, of WHO is the member states. What I would say is what I've learned over the past 2 or 3 years, and I'm not a UN insider, I'm here with a fresh outside look, is that this governance platform of 194 member states is on balance a strength of the World Health Organization. If you compare it with other groupings of 20 countries or 7 countries or 77 countries, or sometimes even just a couple of people, the strength is the inclusiveness of the 194. And then the question is how you organize that. So the 194 member states, and this is very much in the proposals for how to move forward and strengthening existing institutions with good governance platforms as opposed to new ideas. That's a very active debate. This is an asset. It's a comparative advantage. And I know people don't always see it that way. I had my own questions before I came, and I see it as a huge strength. To your specific question about hiring practices, I mean, that goes to the processes that are very much part of Dr. Tedros' transformation. There's a lot of fair process around these things. And it also goes to diversity, equity, and inclusion. And all I would say is, if you look at the senior management team of WHO now, it is a highly diverse group in terms of geographic origin, in terms of gender, and that is a significant improvement. And we had targets around this in 2017. And this is, I think, implicit in your question also, and it really reinforces the performance-based culture, a diversity-based culture, and the transformation that WHO is undergoing under Dr. Tedros' outstanding leadership. Because at the end of the day, it is about leadership, many of the questions that we're discussing here. And in closing on this comment, work with us, join with us. WHO is us, and we very much want to partner with every single person listening and every single person in your network, Keith.
Thank you very much, Peter. And I think that we all felt for the WHO when certain countries are really trying to perhaps use their economic muscle to lean on you. And you made the really stark illustration that the WHO's budget, only 20% of its budget are assessed contributions, 80% are voluntary contributions, which puts the WHO in a terrible situation. And personally, I think that, and it's been called for, that should be flipped at least. So 70% of your budget, as you said, increase in size, but also increase in the ability of what you have, and it should be flipped. 70% of your budget should be from assessed contributions, 30% from voluntary contributions, but that would give you the economic power and the size of your budget to carry your life-saving work out. This question comes...
If I may, I'm sure Soumya and Samira will want to comment. These things are all important, and at the end of the day, it boils down to leadership, and we've really benefited from Dr. Tedros' calm and principled leadership through a very turbulent time for the world. I think the whole world has benefited. And so finance, yes, science, yes, data, yes, triple billion, yes, technical, yes. At the end of the day, a lot of things rely on leadership. And I think WHO has really benefited from Dr. Tedros' leadership over the past period of time.
Indeed, thank you. Absolutely, most certainly, Peter. Thank you. This question, Samira, comes from Michelle, and she's asking about the high-level independent G20 report on pandemic preparedness that was just released. We're having actually a webinar on this coming up in early August, by the way, with Dr. Victor Zhao, the head of the National Academy of Medicine here. But the question that Michelle has is, there's been a report about the asking for the development of a global health threat board financed independently. Now, do you think, Dr. Swaminathan, that that the WHO should be integrated into this independent board, or do you think that there are too many cooks in the kitchen, so to speak?
Well, what I think is that the WHO needs to be strengthened. It's not going to be replaced by any other body, as far as I can see. I mean, its constitution still encompasses all the functions that you can think of. It needs to be strengthened. It is being transformed, and it has to keep improving and growing. The Global Health Threats Board would be a political support system for the WHO, because at the World Health Assembly we have ministers of health, and so if you had something that was at the level of the heads of state, for example, that would periodically look at health threats, so the WHO would report to them or work with them to discuss the health threats. It could be a pandemic, it could also be the health effects of climate change, for example, things which need political leadership, commitment, resources, and a global approach, a global solidarity type approach to solve the problem. I think that's where a global health board could be very useful, because then you're elevating health to the level of the heads of state, which is where it really needs to be. Otherwise, problems don't get solved from our experience. And so it would be a facilitating mechanism. It would give WHO even more strength and backing to do the things that technically we know need to be done, but you need the political will to get it done.
Keith, I would like to come in here to add to what Soumya and Peter said. You may have heard of the Universal Health Preparedness Review. It is a mechanism that Dr. Tedros announced last year, as well as during this World Health Assembly, and the process has begun with an initial 12 member states. This is a truly game changer, a multilateral cooperation platform where countries have a dialogue and identify the core preparedness capacities and the weak links and share the expertise. WHO is serving as a secretariat. We have done the outline and will begin the process of piloting and presenting the results at the executive board in January to all the member states. So we have had regular briefings with member states about this, and we have a brilliant set of initial countries representing most of the continents willing to participate in this peer-to-peer multilateral preparedness review. Not as naming and shaming, but rather than a very constructive cooperative dialogue. So this would, I think, if goes well, will truly be a game changer.
Well, Samira, Stelia, this question that actually was leading up to Soumya's question, actually. So it really goes to your point about how has the WHO evaluated its own response so far in the COVID-19 pandemic, and has it changed the way? How has it changed the way that it's interacting with countries with regard to its own accountability to those countries? Has there been a change in how it sees itself accountable to countries in its response to the pandemic?
Well, I think one of the things that we do is self-reflection and introspection, and see where we can. And we've had to, build the boat while sailing it, or build the plane while flying it, or whatever, because, as I mentioned, particularly around the guidance, early on, we didn't know much about this virus. We had to come up with guidance. And so you had to rely on historical data from other coronaviruses, but keep updating it as more and more information came out about how this virus behaves and what sort of clinical. And then, of course, on the transmission question. Now, when we look back, we have many oversight mechanisms. So we have the Independent Oversight Committee for the Emergencies Program. They do a very thorough job. They meet every 3 months, chaired by Felicity Harvey from Public Health England, it used to be Public Health England. Excellent group. They really look at our response, and they talk to each one of us when they come every 3 months to go into depth into our response and really try to find out where we did well and where we have to improve. And they give us a report, and then we have to report back to them. So there is that. And then we have, of course, the larger oversight committee that looks at all of WHO. But in addition to those external bodies, I think even today we're looking at, on the R&D side, the blueprint enabled us to really launch the research roadmap and the research efforts around the world. But we know what the gaps were. We know where we need to strengthen further. We've identified areas around ethics, around regulatory harmonization that definitely need to be done better. And it's not just WHO. So WHO needs to work with member states and say, we've identified these barriers. Can we do better next time? And how do we improve things before we're hit with the next emergency?
Yeah. Sorry, just to fully agree with what Samira and Soumya just said, and also just to point out that the whole system matters. So one of the most surprising things is there's about a 50-fold or greater difference in cumulative mortality among G20 countries. And so WHO has a very important role in the response. National leaders and leaders at all levels in countries have a very important role, as does the multilateral system and other partners like the people on this call. So very important to look at the whole system together and that operate together well.
Well, that's a great lead off, Peter, into this final question before we go into, if you have any final comments, we'll go in reverse. And Dr. Asma, Dr. Somanathan, and Dr. Singer will close with some final comments. But that lead off works perfectly, Peter, into your first comment about that we're far away from the SDGs. The pandemic has really crushed our ability to actually meet the Sustainable Development Goals. So Samira and Soumya, this gets to non-communicable diseases responsible for 70% of the world's death. How do you see, and how can our members as academic institutions, how can we work with the WHO to be able to engage in the public health strengthening that will come out of the pandemic, but not only deal with the prevention, detection, response to infectious diseases, but even perhaps as important, more importantly, deal with the ability of low-income countries to strengthen their capacity to deal with NCDs? How can we strengthen public health capacity from stem to stern, particularly in low-resource countries where NCDs hit the hardest? Please.
Sure. So 7 out of 10 leading causes of death that we reported just last year were non-communicable diseases. And the leading risk factors still remain tobacco, high blood pressures, artificial trans fats, high sodium. So there are policies and regulatory measures that are at the disposal that we could immediately address. Hypertension is easy to treat, but it is hardly treated. So there is a whole government approach that needs to happen. And as we mentioned to you about the 3 billion targets, the risk factors, a number of those are NCD related, and NCDs themselves, diabetes, cancer, and cardiovascular diseases. All of these have indicators and the process indicators as to how we track from baseline to the targets and what are the policy interventions that are needed, whether it is public policies, environmental, or treatment and care, including healthcare workforce, etc. And then the generation of new leadership that is needed here through the academic institutions and the consortium, I think is going to be important. Long COVID and the impact of COVID on NCDs and how NCDs have contributed, I think that needs to be unraveled more and studied more in detail.
And I would just add that, I agree with everything Samira said. Every country needs to understand the burden of their own disease. Most countries do not understand what their disease burden is. They depend on some big global modeling exercise to tell them, because of the lack of data. In India, I led the first burden of disease study in 2016, working with Chris Murray and his colleagues. For the first time, we had state-level disease burden, and state ministers could see exactly this, what we're talking about. The second thing I think is that we have to go beyond the ministries of health, because many of the upstream determinants of health are sitting outside health ministries. You have to look at things like air pollution, of course, water sanitation, housing, road safety, things like that. So a lot of people die premature deaths because of things that are happening in these other sectors. And then thirdly, you have to work with communities, because a lot of these NCDs, you need policy changes like the ones that Samira talked about, but you also need individual behavior change. And that's where behavioral insights and social and behavioral sciences comes in. So for an effective public health response, you need not just the knowledge of what needs to change, but how are you going to get the community to change, or in an individual, to change behavior? It's not easy, as we've seen in this pandemic. And so you need all of those inputs into the health system. And then finally, you need, of course, investments in primary health care, because if you expect someone with high blood pressure, diabetes to travel 300 miles to get their medicines every 15 days, they're not going to stay on treatment. So you need to have strong primary health care system where the individual can get quality health services, at least basic health services close to home.
Biggest cause of death, NCDs, biggest cause of suffering, mental health. We can tackle both together, and primary healthcare is a very important challenge, as Soumya and Samira said. Very important platform for doing both.
Absolutely. The whole, and I'm so happy that at our meetings we've actually also brought in the surgical component too, to ensure we know that we can achieve NCDs without having a strong public health primary care and access to quality surgical care. So I know that the WHO, you're all working tirelessly to be able to do that and strengthen low-income countries in particular ability to do that. So we'll close with final comments, and we'll start with Dr. Singer, then Dr. Swaminathan, and then finally Dr. Asma. Please
Sure.
go ahead.
We were going to go in reverse order.
Oh, I'm sorry. Yeah, no, I'm breaking. Dr. Asma, please go ahead. No, thank you for correcting me.
I just want to say, Keith, I'm a big fan of the Consortium of Universities for Global Health. I have worked with you before in my role at CDC. So really hoping that this webinar ignites a revived partnership with WHO, and we could do more, faster, better. So look forward to working with you.
Oh, thank you. We look forward to working with you too, Samira, and thank you for being here and for all the work you've done and continue to do. Dr. Swaminathan, please.
Yeah, what I'd like to see is a new paradigm, really, learning from the pandemic on how we do research and development. For product development, because we, as you mentioned, a huge proportion of the world's population lacks access to essential drugs. Insulin is a good example, but there are other essential drugs like that in rich countries and in poor countries. So our model of R&D needs to change. We need to think about health as a global public good, and high income, upper middle and middle income countries all need to think about, when they invest in research and in development, how can they ensure that access to health products is built into the funding right from the very beginning, because we haven't spoken about it today, but all of us are acutely aware of the inequities in access to COVID products, whether it's diagnostics or vaccines. And this is true for many other diseases. And I think the inequities in our world today need to be addressed. And we have the tools, science has the solutions, we have the technologies, digital, we can reach people. We just need to have the will to do it.
Yeah, no, thank you, Dr. Swaminathan. We know how to deal with the NCDs, and it's that gap is colossal, and it's unbelievable, particularly in India, the hypertension impact and the lack of access. I think only 5% of people in India who are hypertensive actually are fully controlled. It's a profound human tragedy. Thank you, Dr. Singer, please.
Keith, thank you. And what I would just say is that the pandemic has been an X-ray of our soul. The pandemic has been an X-ray of our character. And, I think one of the things that many of us have learned is maybe we don't express enough gratitude for the things that we each do and we do together. So with great humility, I just want to express on behalf of WHO great respect and appreciation, Keith, to you and to the CUGH for the work that you do, the Consortium on Universities in Global Health. I want to express my thanks and gratitude to these fantastic colleagues that you see, Samira and Soumya, and their wonderful science-based and data-based and evidence-based leadership powering us towards universal health coverage and healthier populations and health emergencies and better preparedness, and other colleagues. And I want to express, again, on behalf of WHO, our great respect and appreciation for the colleagues that are listening to this, that are working every day. I see many of the names on Twitter just now, some terrific and fantastic colleagues who are working every day to make the world a healthier, a fairer, and better place. And so our respect and appreciation to all of you, our thanks for the work that you do. And with great humility, we ask for you all to even double down and strengthen your partnerships with us, because when we talk about strengthening WHO, that's actually what we're talking about. We're talking about strengthening our relationship with you, strengthening our support to member states, and strengthening together and accelerating our journey to a healthier and fair world. Thank you so much, Keith, for the opportunity you've given to WHO to participate in this webinar today.
Well, thank you so much, Peter, Soumya, and Samira. That is a wonderful encapsulation from all of you and what you have, your aspirations for the future. On behalf of all of us at CUGH, we'd like to thank you and all of your colleagues around the world and all the country offices that are working tirelessly to improve the health of people everywhere as your mission, particularly those who are most vulnerable. And at CUGH, we are committed and ensure that everybody who's listening to this, that we need to ensure that we work hard together, because as I said initially, that the WHO is us. The member states determine the policies. We can change those. We can work hard to strengthen them. So all of us who are part of the global health community, we need to assert with our governments what our governments should be taking to the World Health Assembly to strengthen the funding, the governance, the science, and the data for our individual and for our collective health, and also to ensure that those firewalls are in place to prevent any country from being able to use their influence through funding to pressure the WHO to do what it wants to do rather than what should be done and what the WHO wants to do on behalf of vulnerable people around the world. So thank you for joining us. This webinar will be on CUGH's website. I'd like to thank Jenna Smith for her perpetual hard work in producing these webinars. And we encourage you to take a look at our upcoming webinar on the G20 Special Report with the National Academy of Medicine coming up in early August. See it at cugh.org. And to all of you, thank you for joining us, and we hope you have a wonderful day. Bye for now.
Thank you. Bye-bye.